Introduce Dr. Viviano.
Thank you, Heidi. Thank you all for attending our webinar tonight. Dental Services Group Laboratory is a group of full-service dental labs throughout North America. We've been helping dental teams initiate and successfully implement dental sleep medicine into their practices for more than 25 years. My name is Joanne Friedman, and I am with the Canadian DSG Labs based in Toronto. My colleague, Veronica Brown, is based in Ottawa, and together we service our customers throughout Canada. We're happy to help guide you through the dental sleep journey. In the follow-up handout, we will also provide the contacts for our USA-based colleagues as well. It's my pleasure to introduce Dr. John Viviano. We've worked together for many years, and I'm always learning something new from him. He's extremely knowledgeable, evidence-based, and passionate about dental sleep medicine. Dr. Viviano is always willing to share and help further the practice of dental sleep medicine. Dr. Viviano obtained his credentials from the University of Toronto in 1983. His clinic is limited to managing sleep-disordered breathing and sleep-related bruxism. He's a credentialed diplomat of the American Board of Dental Sleep Medicine and has lectured internationally, conducted original research, and authored original articles on the management of sleep-disordered breathing. His clinic is the first Canadian facility accredited by the American Academy of Dental Sleep Medicine, and he is a clinical director of the Sleep Disorders Dentistry Research and Learning Center. Dr. Viviano also hosts the Sleep Disorders Dentistry LinkedIn discussion group and conducts dental sleep medicine CE programs both online at sddacademy.com and in class for various levels of experience, including a 4-day mini residency. I encourage you to write your questions in the Q&A as we go along because we usually have quite a few questions. Dr. Viviano, go ahead.
Thank you very much. And thank you, Joanne, for inviting me to do this tonight, speak about something that I'm obviously very passionate about. And I'd just like to clarify that tonight is an introduction to dental sleep medicine. What it's really meant to be is, what's the reason you should get involved? You know, you're a dentist, you're out there, you're practicing dentistry all day long, every day, and you keep hearing about dental sleep medicine. What is this about? And tonight is to answer that question and hopefully to leave you compelled to want to become involved and add this to your practice. Next Tuesday is for the experienced clinician. I'm going to be talking about some very recent research and putting it all together for you, giving you verbal skills that you will be using the very next day in your practice. So it's more of an advanced program, but obviously it would be of interest to anybody interested in dental sleep medicine, even newbies, because you're going to have to learn that stuff as well. So this is part one, which is the introduction, and next week is more of an advanced program that takes things to a much higher level. Okay. So let me see, of course, as soon as you go to advance your slide, that's when it doesn't work. So we'll just do it the old fashioned way. There you go. So here's my office and, you know, a few pictures of our courses and so forth that I just like to share. And by way of disclosure, no vested interest in any appliance, device, or technology. I maintain a sleep disorders dentistry practice, conduct research, and provide educational programs. Our facility is accredited by the ADSM, and the facility and all the programs follow AASM and AADSM guidelines. Tonight, basic review of sleep disordered breathing, current sleep disordered breathing treatment options, exactly why you need to become involved, and the impact of COVID-19 on sleep disordered breathing options, something a little bit different because of the current environment we're in. So I'd like to start off with a poll, and we'll be actually repeating a poll and a similar question at the end of today's session. So if we could please put that poll question up.
Are you able to see the polling question?
I'm able to see it.
Okay, perfect. We'll just give it about a minute.
There's also a note here that says that the host and panelists can't vote. So it's only for the attendees. So we can't sway the results.
Okay, we're about 50% there. Looks like people are still voting. Okay. And we are almost there. Okay, we're ready to publish the results.
So 50%, I do not routinely screen my patients. 8%, I routinely screen my patients for sleep apnea. And 25%, I routinely screen, but I refer it out if, to get managed. And 17%, I routinely screen and also manage the therapy through oral appliances. So it's interesting. It'll be interesting to see at the end of this session if those numbers change. So sleep disordered breathing refers to abnormal breathing during sleep, still often ignored by primary medical care. I used to be able to say that. I've been doing this for 25 years, teaching for many of those years. And at one time, the primary care physicians, the family physicians, you just snore, you just go sleep in the other room. But they've caught on and they're actually become very knowledgeable about referring appropriately. But what they aren't knowledgeable about is oral appliances. So oral appliances are still often ignored by the primary care physician as an option. And not only primary care physician, but also the sleep specialist. Of course, sleep disordered breathing is associated with major health consequences. In the dental office, is ideally positioned to screen, refer, manage, and monitor these patients. It leads to insufficient ventilation. In other words, you're being deprived of oxygen. It's a collapse of the airway, as you see in the little image there with the circle, the red circle. And this collapse of the airway has to happen for at least 10 seconds or more. And you get arousal from a deeper stage of sleep to a lighter stage of sleep and a blood oxygen desaturation happening. Or shallow breathing that also involves an arousal from deeper stages of sleep, and it could be with or without blood oxygen desaturation. Of course, all of this results in disruption in your sleep cycle. Every time you get into a deeper sleep, your airway collapses and you're brought up to a lighter sleep. If somebody's poking you in the arm every few minutes, you're going to have a disrupted sleep and you're going to be tired in the morning. So this leads to daytime fatigue. Your blood oxygen desaturation, resaturation ends up resulting in endothelium injury, the lining of the blood vessels. There's a reduction in nitric oxide. This leads to hypertension, all sorts of cardiovascular disease, heart attack, stroke, and a host of other issues. And of course, deprivation of time during deep sleep, stage 3 sleep, and REM sleep results in physiological processes that need to take place not happening. This is when your body and your mind voids itself of toxins. This is where muscle repair happens. There's certain hormones that are being produced that impact an appetite, blood sugar levels, so diabetes is a concern. Deprivation of deep sleep and REM sleep is a big issue. So how is it remedied? Well, you can use pressurized air. This is CPAP, continuous positive airway pressure. Blows air into your nose, down your airway, pneumatically splints it open, and it works. It'll always maintain the airway. They can always find the appropriate air pressure to maintain the airway. Or an oral appliance in the mouth. The appliance holds the jaw in a particular posture, and the posture impacts on the airway through muscle activity, helping to maintain it. In severe cases, sometimes, a combination of both CPAP and an oral appliance are used. So to put some perspective as to the meaningfulness of this sleep disordered breathing thing. It's associated with hypertension, atherosclerosis, myocardial infarction, chronic headache, increased risk of error, so you're more accident prone, decreased focus, daytime vigilance is reduced, loss of energy, loss of interest, feelings of worthlessness, depression. Type 2 diabetes, glaucoma is associated with sleep disordered breathing, loss of hearing, for both the snorer and the spouse, and loss of libido. That should get everyone's attention. With regards to lifespan, this is a 18-year follow-up. What they did is they gave a bunch of folks a sleep study, and then they followed them up in 18 years to find out if they were still alive. There was about 1,500 patients, and if they didn't have sleep apnea, 18 years later, about 93, 94% of them were still alive. If they had mild sleep apnea, about 89% of them were still alive. If they had moderate sleep apnea, about 83% of them were still alive. If they had severe sleep apnea, about 58% of them were still alive. So, significant high mortality risk with untreated sleep disordered breathing, independent of age, sex, and BMI. Simply stated, unmanaged OSA shortens your life. So the cost to the individuals is quality of life, okay, longevity of life, cost to society. There's all sorts of financial costs. It was actually quantified by Frost and Sullivan in a report commissioned by the AASM in 2016 at about $150 billion per year in the US. Workplace accidents, 6.5 billion. Motor vehicle accidents, 26.2 billion. Lost productivity, 86.9 billion. And comorbid diseases, about 30 billion. When we talk about the epidemic that we're in with COVID and how it impacts people worldwide, becoming really a pandemic, this sleep disordered breathing issue is approaching 1 billion people worldwide. In the US, 20 million have asthma, about 24 million have diabetes, about 30 million have sleep disordered breathing. Yet, more than 80% of severe sleep disordered breathing remains undiagnosed. This percentage, I've seen it go between 80 and 90%, depending on which paper you're looking at. Okay, so the majority of sleep disordered breathing remains undiagnosed. We're just scratching the surface of the problem. Okay. Now, this is US statistics also, a market research project conducted by ResMed, which is actually the inventor of CPAP. 30% referred don't get tested, 82% would be positive, and 50% give the reason, I don't want to use CPAP. So almost 1 million CPAP non-compliant yearly is the end result. Many unaware of alternative options. They have other types of PAP, positive airway pressure machines, called auto PAP, and these are sometimes more comfortable because the pressure regulates up and down as it's needed. They're not aware of oral appliances or combining the therapy or other therapies. 5.9 million have been diagnosed in the US, according to this Frost and Sullivan report, as of 2016. 60% remain compliant with treatment as of when they did that study. 40% non-compliance cited the reason discomfort and inconvenience of CPAP. Not offering these patients a viable alternative results in similar consequences as if they had never been diagnosed in the first place. I mean, you diagnose them, you give them something, they don't comply, and then you just abandon them. Well, it's the same result as if you didn't even diagnose them in the first place. Problem with that, I think. But you can say, well, at least we're helping 60%. That's pretty good. Well, are we? This is a study of almost 3,000 patients. It's a multi-center study. What they did is they took cardiovascular risk patients, and half of them, they had them wear CPAP, and the other half, they used usual and customary protocols only. And what they found is after 7 years, there was no significant difference in the prevention of cardiovascular events comparing CPAP versus the controls. That's crazy. What would the reason for this be? Well, when they dug into the data, what they saw is that compliance was 3.3 hours per night. So what this tells us, because other studies have shown that you get cardiovascular protection if you're wearing your CPAP. But what this shows us, if you're not wearing it long enough, you don't end up with the cardiovascular protection we're looking for. Interesting thing here is that it's well established in the literature, this compliance issue. I'm just going to quote this directly. The rate of CPAP adherence remains persistently low over 20 years worth of reported data. This low rate of adherence is problematic and calls into question the concept of CPAP as gold standard therapy for OSA. That was a series of 82 papers, comprehensive systematic literature review. So this concept that CPAP is gold standard for sleep disordered breathing, I think there's overwhelming evidence that the emperor has no clothes, said the young boy that grew up to become a dentist. Clearly, CPAP is gold standard for the 1/3 of patients that can actually comply with wearing it all night long. But the people that are not wearing it all night long are not getting the cardiovascular protection we're looking for. And the people that can't comply at all are not getting any benefit and are typically abandoned. We can do something about that. So why is this low CPAP adherence acceptable to physicians? I scratched my head over this for a long time. CPAP adherence, 29 to 83% non-adherent, defined as a mean of less than 4 hours per night. So if you're wearing your CPAP 4 hours a night, you're compliant. Okay. Mean use of 3 hours per night is among the non-adherent patients. So the people that are not really adhering to it all night long, typically wearing it 3 hours per night. Well, when we look at hypertension meds, 50% of the time people take it the way they're supposed to. When we look at asthma meds, 12% use asthma meds as prescribed. Okay? As a matter of fact, right across the board, when medicine is accustomed to patient non-adherence, with only 25 to 30% of prescriptions being taken as prescribed. So physicians look at CPAP compliance as being pretty darn good. They're at least as good as the average prescription, if not better. CPAP therapy pumps air into the airway through the nose, 65% compliance after 6 months in this particular study, an average of 3 to 4 nights a week, 3 to 4 hours a night was the average for this study, okay? And they considered that compliant. Adjusted nasal CPAP effectiveness, when one considers both the amount of apnea reduction plus also how long they're wearing it, the adjusted effectiveness is 50%. Oral appliance therapy holds the jaw forward, maintaining the airway. Well, multiple studies show us approximately 90% compliance long-term. Health outcomes are similar to PAP, likely due to the superior compliance associated, even though we don't always get the apnea all the way down. So, interesting, Van der Veeken published in 2013 something called mean disease alleviation, and he came up with an adjusted oral appliance effectiveness of 51%. So the adjusted effectiveness of oral appliance therapy is equal to CPAP. Physicians don't think of it in those terms because what their concept is that you have 50 events per hour. I know if I apply a CPAP to the situation, I'm going to get that down below 5. With an oral appliance, you may get it down below 5, or you might get it down to 12, or you may get it down to 25. And it's a little bit of a roll of the dice. And it is, unless you do, a predictive study like with the Matrix Plus, which we have available to us. So we actually are able to predict ahead of time whether an appliance would work before we even make an appliance, but that's another story. We're talking about just coming out of the gate. It's a little bit of a roll of the dice as to whether you'll get the apnea all the way down. Even though the mean across a group of people, it'll be a similar outcome. But let's take a look here. This is a conceptualized comparison of treatment performance of continuous positive airway pressure and mandibular advancement devices. When it comes to reducing the apnea level right? The polysomnographic efficacy, which means the sleep study efficacy, CPAP wins every day of the week. However, when it comes to symptom control, this is a similar result. When it comes to health benefits, it's a similar result. When it comes to adherence, oral appliances win. When it comes to tolerance, oral appliances win. When it comes to patient and partner acceptance, oral appliance wins. When it comes to convenience, oral appliances win. And when it comes to affordability, this varies depending on the geographical region you're in, the country you're in. Insurance policies are different. There's socialized coverage in some places and not in other places. The overall cost is similar. There's many studies that have been done on this showing one over the other, but it's a similar cost. The cost of the patient varies depending on the insurance status in that particular region. If we look here, a 1-month health outcomes follow-up, you can see right across the board that oral appliances are either non-inferior to CPAP or superior in some domains. The only area they're inferior is the ability to get that number of events down to below 5. So that's an interesting question. Oral appliances are not as predictable at getting the apnea down below 5, yet all these other categories, they result in a similar outcome. Well, this will help you understand. SomnoMed, largest oral appliance manufacturer in the world, has put together this software package called the effectiveness equation. And they show, they give you the ability to input CPAP results and oral appliance results, and then it does a calculation to give you a comparison to see how effective things are. CPAP, you can see baseline here, 119 events per hour, and treated with CPAP was down to 3. It's a marvelous result. Here with the oral appliance in place, baseline's 119 events per hour, and it reduced the apnea level to 29. Well, no physician in the world would be happy with this result. No dentist in the world would be happy with this result. You're still leaving the patient with a high level of moderate. You're one event away from being in the severe category. However, it's really interesting when you factor in that this particular patient wore their positive airway pressure or their CPAP for 4.5 hours per night versus they were able to comfortably wear their appliance for 7.5 hours per night. If you do the math, the total number of apneic events with the CPAP is 430 for the duration of the night, and for the appliance is 277. I mean, that even boggles my mind when the first time I saw that and realized this, because unless you actually crunch the numbers, it's hard to fathom that this is actually the way it would turn out. And I think this goes a long way to explain why oral appliances end up with a similar outcome with regards to medical issues they're trying to manage, even though they don't always reduce the apnea down below 5. Now, does that mean that accepting 29 events per hour as being okay is fine? And of course, the answer to that is no. But what we do is we adjust the appliance further, perhaps try different vertical, or we use adjunctive therapies like position or weight loss or additional surgeries or muscle training, myofunctional therapy, or actually using it in conjunction with CPAP. We use adjunctive approaches along with wearing the appliance to get that 29 down further. This is the mean disease alleviation that I mentioned earlier, published by Van der Weken in 2013. And you can see it here that with CPAP, 90% effective, but at reducing the apnea, but 56% compliance. So their Achilles heel is compliance. So what happens when you have a patient that's non-compliant? Well, you use a different mask. And so sometimes patients go through 3, 4, 5 different masks before they finally abandon CPAP. Or you reduce the pressure. Well, if you're reducing the pressure to make it more tolerable for the patient, you're also reducing the efficacy. So they will have residual apnea that they're dealing with. Or AutoPAP. So the machine ramps the pressure up and down as needed, and some patients find that easier to tolerate than the continuous positive airway pressure. With an oral appliance, overall effectiveness is found to be 56%, but you can see here the compliance is like 91%. So the mean disease deviation being 51, which is similar to the 50 they get with CPAP. We won't mention that it's higher. What do we do? The adjunctive therapies we do in this particular case are, well, maybe we could advance them further. What they can't comfortably wear today, the position, doesn't mean they won't be able to in 3 months or in 6 months. So sometimes it's a journey of several months to get to the best and optimum position. Or you can try altering the vertical. Sometimes opening up the vertical a bit is all that's needed to remedy the problem. Or you employ positional therapy. You have them stay off their back, for instance, or weight loss, the direct relationship between weight and level of sleep apnea, combining it with oral appliance therapy, other lifestyle changes like alcohol and smoking and exercise and fitness and so forth. Various surgeries are available. And tongue muscle tone, there's a device called the Suzil. The name change just happened. I heard about yesterday. It's now called the Excite. And what it does is it uses neuromuscular stimulation to change the physiology of the tongue and make it have better stamina. And so this is something that could be used adjunctively along with an oral appliance or myofunctional therapy. So an appliance is either the journey or it's the start of the journey to wellness, okay? Oral appliance market trends, I'm gonna have to trash this slide soon because I've been using it for years and we're at 2020 now. And so we can see here that about 80% of the time, patients are prescribed CPAP. We know that about 40%, half of them won't use it. So what happens to the 32% of CPAP prescriptions that don't comply? Well, unfortunately, all too often they remain unmanaged altogether. So we need to increase awareness for oral appliance therapy. We need every dental office out there talking to their patients, making sure the patients are aware, screening patients, and quite frankly, hopefully many of them getting involved in the management. So you've heard the term, you know, you're too close to the forest to see the trees. Well, you know, if you're looking into a forest, there's a whole ecosystem in there. So all this different stuff going on, different trees and different varieties, different species. But if you're too close to it, you can't really see much other than what's right in front of you. And so I'm going to look here, this first set of trees, these are patients that wear their CPAP all night long, and it's about a third of the patients that are prescribed. And then the next third, they wear their CPAP part of the night and then take it off. So, you know, they're suboptimally managed. They may be getting some help. They may feel better when they're wearing it, but they're likely not getting a cardiovascular protection, which is probably something everybody is hoping for. Okay. And then of course, there's the 1/3 of patients that are not being helped at all whatsoever. So there's a whole forest of trees. Well, physicians, their optics are looking at it from this direction. And what they say is, well, we're helping 2/3 of patients. You know, the first 1/3 we're helping marvelously, and the second third we're you know, giving them some help, right? And dentists that are involved in this area are looking at it from this angle, and they're saying that, well, wait a second, you're missing it for 2/3 of patients. You know, you're not helping a third at all, and 1/3 you're only helping suboptimally and not getting them the cardiovascular protection they need. So your point of view depends on your optics here. The standard has been that CPAP is gold standard. Everyone gets offered CPAP up front. Oral appliance therapy will likely not work for moderate to severe cases, using the criteria of getting the apnea level to below 5. With better dental collaboration, you'll still hit it for the first third the ones that will wear their CPAP, and you'll optimally manage them. But for the CPAP semi-compliant, consider an oral appliance to improve their outcomes further. And certainly for the CPAP non-compliance, consider an oral appliance to get some level of outcome for them. You know, these people are being ignored by the system. They fall through the cracks and they're gone. So what we need to know as far as the current guidelines for oral appliance therapy, if the behavioral therapy can't manage it, simply like sleeping on your side versus your back or losing 5 pounds, well, if there's snoring, oral appliance therapy is first-line therapy. If there is any level of sleep apnea, CPAP is gold standard, first-line therapy. However, this is where physicians stop typically. But the next part of the guideline states that if a patient is PAP intolerant, or simply prefers an oral appliance to PAP, then an oral appliance is a standard of care for all severity of sleep apnea, mild, moderate, or severe. The medical guidelines could not refer to oral appliances as the standard of care for all severities of sleep apnea unless there was sufficient evidence in the literature to demonstrate they do work at all levels. The difference is that the higher up the number, the less the probability that you're going to end up going all the way down to below 5. Now, here's a case where a sleep specialist did not want to write a prescription. So I obtained a prescription from the family physician because any physician can write a prescription. Now, interestingly, he spent 27.1% of the night with his blood oxygen below 90%. This is very meaningful, okay? He had 72 events per hour on his back and 23.5 events per hour when he was sleeping on his side, okay? His index was reduced to 2.4 overall and 2.8 on his back with an appliance. So think about it. If this patient had been prescribed CPAP and left with that option only, he voiced his non-adherence clearly. He would likely die younger than he needed to. By providing options, you will have better outcomes. And I'm going to take it a step further. If you do not provide options, or if you discourage other options, then you're actually doing harm. Telling a patient appliances don't work or will not likely work may be steering them away from the only effective conservative therapy currently available. And that should be criminal. This is an example of a patient that came to see me in my clinic. He stopped breathing when he was on his back 171 times an hour, and when he was on his side 118 times an hour. He had a BMI of 41.9. His overall index was 139 events per hour. By anyone's standards, this is not oral appliance territory, and an appliance would not work for this individual. He asked me, so will an appliance work? And I looked at him, I said, well, I can't with clear conscience answer that question, but I can provide a matrix plus study where we place a device in your mouth, the jaw will move forward and back all night long. It's a 2 to 3 night study, but it'll give a prediction as to whether an appliance will work. Here's a picture of John Remmers with my Elaine at the office, and he's holding the device that he invented here, the Matrix Plus. It labeled him as a responder. He had to wear his device 95% of his full protrusion. I discussed this with him and says, well, it says it'll work, but you have to have your jaw pretty well all the way out. Can you do that? And he felt he could. So we made him, we made him a tap appliance. And I gave him the tool. He slowly moved himself forward to get to max protrusion that he could comfortably tolerate, sent him home with a Knox T3 sleep study device to evaluate the change. And you can see it brought his index down to 2.5 events per hour. On his left side, 2.1, on his right side, 3.1, and on supine position, 2.5. Well, after rubbing my eyes, I said to him, you know, can you take this device home again and do 2 more consecutive nights? Because I want to double check. So he took it home a second night and 2.9 events per hour. And then on the third test, 2.2 events per hour. 3 tests, all under 5 events per hour. This is a copy of the report that I sent to the physician showing the severity at baseline and what we did with the oral appliance. Please contact the patient to either a consultation or follow-up in lab sleep study, depending on your protocols. You'd think I'd get a phone call from this physician saying, good job. No. Okay, now we'll get on to little interesting little twist, because we're in this COVID environment right now, which is nuts, everything that's going on. And I mean, it's just a crazy time that we won't forget soon. So the question you may be asking is, okay, isn't PAP first line care for managing OSA, right? What's this oral appliances versus PAP thing? Well, the answer to that question is no. Let me explain how I come to that conclusion. So COVID-19 pandemic has highlighted medical implications of PAP aerosol. We all know about dental aerosol, and you know, it impacts on everything we do on a daily basis at the office. Well, PAP, positive airway pressure with a mask interface, creates aerosol as well, okay? PAP implicated with the spreading of COVID-19 within the Washington State nursing home that became ground zero in North America. Quote unquote, we essentially aerosolized it, said one responder, one of the firemen. We made it worse. The Redmond Fire has now discontinued the use of PAP for COVID-19 patients when they know they're going into a situation where there's COVID-19. PAP mask interface leakage is well established. ResMed acknowledges it. It's not an on-off thing. It's not like it leaks or it doesn't leak. It's a degree of leak. It's a spectrum. So basically, it's okay if it leaks as long as it's not impacting negatively on the therapeutic outcome. In other words, the effectiveness of the PAP. Because they know that they cannot guarantee and assure the absence of leakage. So they can't set that as a standard. So the fact that CPAP masks are going to leak is a given. The question is, what are the implications of the mask leakage with forced air aerosolizing the COVID-19 in a room, in a household where there's other people that perhaps are trying to isolate and keep away from the infected person? They don't really know, but it is a concern. The American Society of Anesthesiologists recently advised against PAP use for COVID-19 patients, and they learned about this in the 2003 SARS epidemic. Basically, PAP pumps virus into the air, potentially spreading disease. Dr. Camilla Sasson, Associate Clinical Professor, University of Colorado School, basically recommends not to use it because we are concerned about community spread. So this is the common consensus. As a matter of fact, in Toronto here, firefighters are told they cannot use their own personal PAP machines if they have sleep apnea at the firehouse. So they are being changed to day shifts and no longer taking night shifts if they have sleep apnea and have to use a PAP machine. The concern, of course, is the potential for spread of the virus, especially in light of the fact that some COVID-19 patients are symptomless. So you never really know whether you're spreading the virus around to the others or not. The AASM currently recommends, so AASM for the newbies is American Academy of Sleep Medicine. So this is the medical organization, recommends that PAP user if they become COVID-19 positive, they should speak to their physician about assessing the risks and benefits. Persons at risk from continued PAP usage include all cohabitants of the household, They're acknowledging this. Patients should not stop using their PAP without consulting with their physician first. If someone has tested positive for COVID-19 or presumes that they have some symptoms of the virus, then they should immediately sleep in separate rooms, isolate, right? And maintain distances even within the same household. They should also speak to the physician to help determine if they should continue PAP use. What needs to be evaluated is the severity of their sleep apnea, the risks of not using their positive airway pressure machine with the risks involved in the household. In other words, are there other very susceptible people in the household that we really want to try and isolate from the virus? Is there ability in the household to be able to isolate? Do they live in an apartment or do they live in a home where people can actually stay on a separate floor? So, there's a lot of different factors that have to be taken into consideration. But the take-home message here, the concern revolves around the potential for the aerosolized virus from the CPAP mask creating a problem. There's been much discussion about this new normal post-COVID. A new level of vigilance will be exercised with the use of PPE in our office. No question, some of the stuff we're doing now is going to stick. Regarding oral appliance therapy, it will be interesting to see if the well-entrenched bias for use of PAP over the oral appliance to manage OSA will persist. Current events may greatly influence the manner in which physicians, dentists, teams, and patients view the oral appliance alternative to manage OSA. Remember, even the best fitting PAP devices leak. This is simply a limitation of the technology and acknowledged as acceptable by ResMed. Now that we know about the liability associated with PAP, we can never unknow it. COVID-19 is not the first contagious virus, nor will it be the last. What are the benefits of oral appliance versus PAP? Well, reduces likelihood of contaminating surroundings with virus-laden aerosol. Ease of disinfection of oral appliance versus PAP. It's quite a cumbersome process to disinfect the mask, the hose, and the machine. Now you've got COVID-19 that you're dealing with, that the disinfection is done properly and safely is even that much more important. An oral appliance, you simply drop it into a glass of water with a little tablet. So this was published in a Journal of Dental Sleep Medicine. Oral appliance therapy should be prescribed as first-line therapy for OSA during the COVID-19 pandemic. Now, this is guidance from the American Academy of Dental Sleep Medicine. Guidance from the American Academy of Sleep Medicine makes no reference at all to oral appliance therapy. They're just saying, be careful. Make sure you consult with the physician, make sure you take into consideration the other individuals in the household, weigh the risks, but they don't direct anyone towards an oral appliance. American Academy of Dental Sleep Medicine is taking the initiative here and saying, look, health outcomes are similar with oral appliance therapy to CPAP. Well, let me read the quote here. Oral appliance therapy is an effective treatment for OSA without increased risk for transmitting COVID-19. Patients who prefer oral appliance therapy may be more likely to adhere to treatment if they are confident that their therapy is not putting those in their household at an increased risk for COVID-19 exposure. Okay, so that's the position of the American Academy of Dental Sleep Medicine. Key points. With patient preference, oral appliance therapy is considered a standard of care for all obstructive sleep apnea severities. PAP creates aerosol and is cumbersome to disinfect. Oral appliance therapy does not create aerosol and it's easy to disinfect. AADSM recommends oral appliance therapy as first-line therapy during COVID pandemic. Given a choice, which would you prefer in a COVID environment? And the take-home message basically is we need to ensure that patients understand their options. As chances are, very few of them are going to hear about the oral appliance option from a physician, because that's a bias that's built in for the system that is simply there because of ignorance. Unfortunately, the American Academy of Sleep Medicine does not really provide physicians much in the way of guidance with regards to the use of oral appliances. And physicians don't spend their time listening to what the American Academy of Dental Sleep Medicine says. So as a result, unfortunately, they remain ignorant. So the only way patients get to hear about oral appliances if dentists get passionate, get involved, and start to spread the word. Oral appliances are known to physicians, and they're exposed to the same information that I just exposed you to, but they are not getting guidance from the top with regards to oral appliance therapy. In my opinion, appropriate guidance right from the top. So there's a built-in bias in there. The patient is entitled to an appliance. It's a standard of care. It's right in both the medical guidelines and the dental guidelines. However, the physicians seem to not buy it or know it or understand it. And the dentists are saying, but it's a standard of care. Why would you not write a prescription? That physician that refused to write a prescription, the patient was entitled to a prescription. That's why I had no problem just going to the family physician to get a prescription. So let's go on to the second poll now that we've shared this information. So similar questions, but basically now that you've heard this information, perhaps some of you for the first time heard this type of information, I'm wondering how you would be responding to those questions.
So we're at about almost 30 seconds in. We'll give it a minute. Thank you for everyone participating in the polling questions. We still have people chiming in, Dr. Viviano, so it'll be just a couple more seconds here.
No problem.
Okay, here we go. And those are the results.
So you're going to have to, do you have access to the answers for the first time around? I think not routinely screen my patients for sleep apnea. I think it was 50 before, right? 50%?
Yes, I
That's
apologize.
what I remember.
I don't have a way to go back, to see those results.
That's what I seem to remember. Do you remember?
It was about that, yeah.
Yeah. Okay, so and routinely screening my patients with sleep apnea, 33%. That's much higher now. I don't recall the number from before. Routinely screen patients for sleep apnea and refer out 11%. And this number is higher too, 56%. Routinely screen my patients with sleep apnea and provide the therapy. That's great. This is exactly the trend that I was hoping for you to see the role that you can play and the opportunity to get involved in helping your patients. I'll tell you, the satisfaction you feel by helping your patients with this type of issue, especially, I'm going to say when they feel abandoned by the system, that it's either CPAP or nothing, and they're not really giving any other guidance beyond that. Or if they're given guidance, if an oral appliance is mentioned, they're basically saying, but they don't often work. They're being dismissed as ineffective. And, the truth is, as you saw from the Matrix Plus study, we have ways to actually test before we even make an appliance, if an appliance works. So, wondering whether the appliance is going to work for whatever severity you have in front of you is no longer a reason to hold back from referring a patient for an oral appliance, because now that can be determined before you actually proceed with an appliance. And next week on Tuesday, we'll be talking, and when I show you the data on the equivalency of oral appliance outcomes to CPAP outcomes, honestly, I think you will be blown away, much like the slide that I showed you on the equivalency equation, where you see how an appliance, although it looks like it's doing worse for the patient, is actually doing better for the patient because of the ability to be able to tolerate wearing it all night long. What we see here is stdacademy.com. This is my online learning platform. The stuff I have up here, everything's free. We have a whole series of Dental Sleep in 5 about different timely topics. I think there's 12 episodes, and then we have about 7 or 8 by Corona webinars that are full-length webinars, and a bunch of chats on our Dental Sleep Medicine Speakeasy that have been recorded and documented about different topics. It's all free. And then we have free online programs similar to the one you just heard, and then a couple of ebooks and some posters for the hygiene ceiling. So please, if you're getting interested or passionate about this, take the time to go check this free content out. There's hours of content there available to you. And if you're interested in actually diving in deeper and taking some of the other paid for courses, right now, all our in-class courses have obviously shut down due to COVID, but we have all of our online content, and we have a special on right now with an 80% coupon for Z Sleep Club, which entitles you access to all of the online paid for content. So, take the time to check that out. And at this point, here's my contact information if anybody wants to reach out to me for any reason whatsoever. And then, of course, we can take some questions. Now, while you're queuing up the questions here, please, I have to go grab my power and plug into power. Otherwise, my computer's going to shut down on us. So excuse me for 1 second.
Thank you. Hi, everybody. Joanne will be
3 or 4 questions.
okay. Perfect.
He'll be back in 1 second. I wonder if that beeping was his smoke alarm or his computer. I thought it was my house. I was running around looking for my smoke alarms. When they start beeping and you want to take a hammer and smash them all.
Yep. Well, we'll just have to let him know about that. It could be the smoke alarm, could be the computer.
Oh, I'm sure you heard it. He was very graceful under pressure.
Yes, absolutely. Well, as we dive into the questions, I'll go ahead and stop recording here.